Yep. So, hi everyone. Thank you so much for joining Professor Clyne's session today. So, Professor Clyne is a medical practitioner with experience in general practice medicine, and organization and management of medicine at local and national levels, corporate governance, business management, and in both undergraduate and postgraduate teaching. He's also Adjunct Clinical Associate Professor, teaching anatomy at the University of Notre Dame, Australia. He has extensive experience in primary care medicine in the context of general practice and is expert in writing considered, detailed, and properly referenced medical legal reports. He has worked with MAC for many years, and we are really proud to have him on our panel. So I'll stop sharing now, Professor Clyne, and I'll pass that sharing on to you.
Thank you very much. So, welcome everybody. I'll just do a share screen. And I'll be checking with you to see that the share screen has actually worked on your end. I'll just be a moment here. And I'll just get this right. I just need to work on 3 screens. And we've got to make sure that the right screen is shared. Okay. So, do you see a clear picture of the first slide?
Yes, we do. Thanks.
Wonderful. It's nice and big in your screen.
Yep.
Oh, excellent. Good. Okay. I'll tell you a little bit about myself. My main areas of medicine now are teaching and in medical legal medicine. I've had about 25 odd years in active general practice. I've taught at undergraduate and postgraduate levels of medicine in presently in anatomy at the University of Notre Dame and its clinical application. I've had about 10 years or so in medical legal medicine. I forget the years, and I would have done around 500 cases. So a few have come past me. The presentation I want to give is not an example of how clever or how stupid one can be in medicine and general practice. Just, how bad the other guy is and how clever I am. In fact, it's a very presentation of very ordinary kind of matter that would come to me for an opinion. It's quite routine, as by routine I mean commonplace. It's purely fictional, but it's meant to demonstrate the breaches of care that occur commonly in general practice. So let's start off. And I'll just have a second. Good. The breach of duty of care in general practice, and that's really what our work is about when we do medical legal reports, is where people have breached their duty of care. Is in general practice is essentially one around process. One part of the process is the diagnostic process. Now, to all the clinicians out there, none of this is new. This is all very basic stuff. You're not going to learn any new medicine here. What I do want to show you is what isn't done. So we're starting off with the diagnostic process. Standard stuff. We teach this, and these days at about first year medical school. When I did medicine, it was 1897. Those of you old enough to remember Hutchinson's Clinical Methods, and I specifically chose that book because it was written in 1897, though this is from the 15th edition. As edition that I used as a medical student. So this is about 1974, 73. Interrogation of the patient, that's the terminology he used in those days. So history, general condition appearances. So general looking, proper examination, and some tests. And it's interesting how Hutchinson uses the word some, because he puts things in the right context. Now, this is now what's been, this methodology obviously still stands. You would not be surprised how often it's not done. And Notre, who wrote his seminal textbook on general practice, it's the textbook on general practice. Again, those of you old enough to remember will have remembered Learning Your Medicine from Harrison's, which is not general practice medicine. It is a presentation of patients, often at a tertiary level, after they pass through many hands, and quite frankly, either at a stage where any medical student should be able to pick it because it's now become so advanced, or it's so rare that it's worthwhile putting into a textbook to show how rare things look. Notre writes about the presentation of matters in general practice, which is different to that of specialist healthcare. It's got to do with the population. A different population sees general practitioners, about 97% of people are well, and therefore the diagnosis, the pre-test, pre-examination probability diagnosis, the pre-test probability diagnosis, all these probabilities are different. The likelihood of, statistically, of a patient walking into a general practice room, where about 97% of people are basically walking well, is about 3%. The proportion of people coming into a consulting room for a hematologist's outpatient is going to approximate about 99% of those people are going to have something the matter with them. And all the numbers change when that happens. The relevance of false positives and false negatives is quite different. Anyway, I'm not going to spend too much time on that. But Notre describes the history of physical and mental examination investigations. And then, of course, we have the axioms. 70% of diagnosis is a history. 25% is a physical examination. About 5% is investigations. They're usually confirmatory. And more is missed by not looking at not knowing. Unfortunately, these days, even in hospital medicine, we are seeing diagnosis being based more upon the results of tests than the use of the senses of the examiner. Another factor of the process of healthcare that is different in general practice, that does not exist in specialty practice, where in specialty practice, it's more of a matter of organ management. I know people might argue about that, but in general, cardiologist takes care of the cardiovascular system, often of the heart, a gut surgeon of the gut. The gut surgeon's not going to worry too much about headache. And a neurologist is not going to worry all that much about lung disease. They'll refer it on. But in general practice, the underlying principle of continuity of care is that whenever a general practitioner sees a patient, it's in the context of all the preceding consultations that occurred, and in the context of the patient's total health care, in taking consideration the environment of the patient, going down to family and community. This is a way in which general practice, another way in which general practice is different to that of specialty practice. And it does impact on duty of care and on the breaches that one sees in general practice. So what I've done, just a list of the breaches of duty of care that I see in the work that's sent to me. First of all, with respect to knowledge, the general practitioner generally does not breach his duty of care or hers simply due to lack of knowledge. not knowing something is by itself not necessarily negligent. What is a breach, or where a breach may arise, I should say, is when the general practitioner doesn't know what he or she doesn't know. Because if a general practitioner doesn't know what he or she doesn't know, then the general practitioner is not practicing safely. The diagnostic process I have listed here, but this is listed in the format of potential breach. A history, failure to take a history. An examination, failure to examine. Formulating a reasonable differential diagnosis. A differential diagnosis must occur in the mind of the general practitioner, and it must be reasonable. And it must be formulated. Tests are done as necessary. And from there you get a narrowed down diagnosis, which is a definitive or working diagnosis. None of this is new as far as what you understand about medical practice. But we're looking at it in the context of breach. And these are the points of breach. And then referral is indicated. Now, coming to referral, all of what I said, all these duties of care, even though it may be poor medicine, and we certainly one would not recommend this as far as good medical care is concerned, proper practice is concerned, but with respect to breach of duty of care, that can all be circumvented by immediate referral to an appropriate specialist. Lousy medical practice, but it will usually and often circumvent breach. On the other hand, just because a general practitioner has referred a patient to a specialist doesn't mean that the continuing duty of care by the general practitioner has been extinguished. The general practitioner cannot just send a patient to a specialist and the patient returns to the general practitioner. Things are obviously going wrong. And the general practitioner says, well, not my problem. I referred it. Somebody else is taking care of it. Not looking at that. Not my department. No. The continued duty of care does continue. As far as treatment is concerned, yes, improper treatment does sometimes occur, but we don't see it too often. It's usually more commonly procedural. The processes that I have described. The patient, the general practitioner gave the wrong treatment, happens, but it's not common. What I've got in this slide here is really a list of the previous processes, but expressed in terms of failures of duty of care, failure to take a proper history, etc., etc. And the consequence of which is a delay in the diagnosis and or treatment, because after all that would need to happen for there to be, or would generally need to happen for there to be damage. However, the causation itself is not something that a general practitioner expert will tend to deal with. That is more going to be in the line of the following opinions of the appropriate expert specialists. For example, for malignancy, it's going to be the oncologist or the other surgeon or physician who's managing that condition. Now, what I've done here is that I have formulated a case study. It is fictitious, but it is eerily accurate. It represents what is seen commonly. And while you will have no difficulty on reading it, firstly, recognizing how pedestrian it is, and don't think that this is going to be these cases are going to be intellectually challenging. This case is not intellectually challenging. It's very obvious. But what it is meant to demonstrate is where the failures have occurred, not what would you do here? Well, when you see this, you'll know what to do. It's very, very simple. But the identification of the breaches is what it intends to show. So here we go. Some background. We have Mr. X. Let's know a bit about Mr. X. He's a 58-year-old man. He's an office clerk. He's been coming to the Happy Medical Centre and the Skin Cancer Clinic. I have chosen the names carefully. This doesn't exist, I'm pretty sure, a Happy Medical Centre and Skin Cancer Clinic. Certainly hope it doesn't. Haven't done an ASIC search, but I don't think anybody would call it that. For 6 years, it's been there seen now by various doctors. So what do we know? It's a group practice. And you get seen by various doctors. This is not irrelevant, because when one is seen by various general practitioners, there must be ensured a way of providing continuity of care. That is that whichever doctor sees the patient, he or she does so knowing what has happened previously. But we know that the patients at the McHappy Medical Centre and Skin Cancer Clinic generally seen whichever doctor is available for them on the day. The fragmentation of care, which this opens up the likelihood, or even possibility to, is supposed to be mitigated by computerized medical records that are available to all the clinicians in the practice. This is a theory. We will see that theory always works. So anyway, at a previous consultation, Dr. B, and his, by the way, Mr. X has come back. He's coming back for a repeat prescription of his statin medication. He's taking it for dyslipidemia. He was at the practice 3 months ago and 12 months ago and a year before that. And is now seeing Dr. A. But at a previous consultation, a serum PSA was ordered by Dr. B as a screening test. Without any prior discussion with Mr. X regarding its indications, utility, or limitations. The result came back okay, 1.2 micrograms per litre, within the normal range. But the test was ordered without explanation. I'll just go back a little bit. Here we are. It was ordered without explanation. The PSA, as you know, is a test that needs to be explained first because it's got serious, significant limitations. And it can set the patient on a treadmill, which they may not necessarily have wanted to get onto. So there was a failure to inform him. But as we'll see later on, it's not material. That means it won't affect what happens as we progress with the series of events that we're going to describe here. So there are breaches. Breaches will happen, but they're not always material to the case. So let's go now to the next slide. So this is Dr. A's consultation. He starts his day's work at the McHappy Medical Centre Skin Cancer Clinic. It's 8 a.m. on a Monday morning. He turns on his computer. And his first patient is Mr. Alfred X, an old patient for practice, but a new patient to him. Dr. A opens the front page of Mr. X's file. And by the way, I've chosen all my wording here very carefully. So none of this is by mistake. He opens the front page of Mr. X's file. He doesn't open any other page, you will notice. Goes to the door and shouts to the room, Alfred X. Oh, by the way, that's my own personal peccadillo. I really don't like when doctors open their door and shout out the name of the next person as if they're ordering a ham sandwich. Usually it's nice to walk up to somebody and greet them, but that's me. Anyway, Mr. Alfred X doesn't seem to not worry too much about it. Certainly Dr. A doesn't. So he goes into Dr. A's consulting room and sits down. Dr. A doesn't know Mr. X, hasn't checked his notes. And it's because he hasn't reviewed his notes, he's vulnerable to a breach of duty of care. To what? A failure to follow up. Follow up what's happened previously. At each consultation, you've got to make sure that there's no unfinished business. But it's immaterial. The PSA was normal. As I said before, the fact that the PSA was ordered without informing Mr. X, and possibly without even telling what was being done, I don't make that clear, is immaterial to this case. Now, I'll just come back a bit. I do follow, I do address this a little bit later. Well, okay, I'll leave it. I'll address it later, as I said I would. Now, here's the discussion. Now, by the way I've done this, we've got the consultations in blue. Then we have the consultation transcript, very simply. Then what actually happens as a result of what is done in green on the right, and on the left in red is an analysis. So it says, how can I help you? And Mr. X says, well, he's having trouble with his waterworks, he's waking in night to have a pee. Now, Dr. A said, it's probably your prostate. And then he goes on to what he thought Mr. A came for, and the first Mr. X came for, which was his cholesterol level. Okay, so says he'll order a test for his urine and the blood for his prostate and check his cholesterol. I was going to come back and look at the results. Well, we know he hasn't checked the previous PSA, immaterial right now. Has he taken a history about his waterworks? He has not. He knows nothing about it except patient's having some trouble and that has some nocturia. As you know, that's not a history. That's a presentation. He fails to take a proper focused history regarding the lower urinary tract symptoms. There's a breach. Is it material? We'll see. Does he examine him? No. So he does fail to perform the proper examination. Now, it needs to be appropriate, it needs to be focused, it needs to be competent, by the way, as well. I think it fix it at the next consultation. So, well, you know, let's see if there's a failure. He can make up for it at the next consultation. But hey, he can do a dipstick. He should do a dipstick. But he orders an MSU. Well, that means that he hasn't actually failed because the pathologist will do it. But he's ordering another PSA. And he hasn't told him about its limitations. But that's not actually necessarily true failure. It's no longer a screening test. It is now done as an investigation. And it's on screening that one needs to inform the patient of the limitations of the PSA as a screening test, but not for investigation of urinary tract symptoms. And that has to do with the false negative and false positive rate, not false, well, it's actually a false negative, false positive, I suppose it is. False negative, false positive rate for a PSA to identify prostatic cancer. It changes because the likelihood increases when a person has urinary tract symptoms. Anyway, Dr. A orders an MSU, serum PSA, does a lipid CK to the function. All right. Slowly digging his hole in the ground, but Dr. A has opportunities to fix that. You know, so far he's staying out of trouble more from good luck than good management. So it comes back at 6.5, people saying, upper laboratory limit 3.2. And a trace of blood on dipstick, microscopy is normal. Dr. A, the blood tests are okay. Mr. X, well, you can see this, can't you? So what's the reason? Just getting older. We'll keep an eye on it. Well, there's a few things here. Obviously, he's wrong. Any second-year medical student will tell you he's wrong. That's not the point. The point is, he didn't compare to the previous PSA. He has no idea of the fact that there's been a change and there's actually been a very high PSA velocity. Yes, I know that people talk about how reliable it is, or think that's, you know, about these things. It's always a matter of putting together all your data. And the velocity is clearly greater than what it should be. It should be no, but what is it? 1 micron? I don't know what it was. but it's a lot faster than what it should be. So he failed to follow up. He appears not to recognize the presence of hemoglobin in the urine. Sure, the microscopy is normal, but there's blood on a dipstick. That means that the red cells have lysed. That's not normal. That's a lack of knowledge. So he didn't interpret it properly. That's kind of, it is an error. So he fails to inform Mr. X properly of the results of urine tests and its possible implications. And by the way, he fails to inform him of the PSA result properly as well. But of course, he didn't know what to inform him of. There's still no history coming up. So now he continues to fail to take a proper history, and he continues to fail to perform proper examination. And at this stage, he could do a rectal exam. Now, a rectal exam before the PSA, sure. Rectal exam for screening, that's not supposed to be very helpful. All it does is increase the false positive rate. But now it's indicated. If he were to refer Mr. X to a urologist now, he could leave it to him. But let's see if he does. Now, he should be either investigating this, and he will then no doubt have to refer, or referring summarily. That means straight away. Well, he doesn't. There is a failure to investigate. I mean, there's stuff he can do. He can do a free PSA. He can do imaging of the renal tract, do an ultrasound. Now, certainly the urologist will do it, but he can prepare the way. And it's a good thing to prepare the way, but he doesn't have to. But then he has to refer straight away. He hasn't really formulated a reasonable differential diagnosis. Basically, he said he's just getting older. We assume that he's thinking about prosthetic hypertrophy, just getting older. He hasn't even explained that. He's failed to inform, as we know. And as a consequence of this, he has caused a delay in diagnosis and therefore of treatment. From where do we calculate the delay in diagnosis? From this day. Because this is the day he could have referred him. And what do we calculate it to? The date that he gets referred later on, which, well, will I give you the answer to what's going to happen later? No. So no funny if I do that. So Mr. X leaves. And by the way, there's something else here. He says, we'll keep an eye on it. Now, I should have mentioned that he hasn't done proper follow-up. He has failure to follow up with respect to not checking the previous PSA, but he's not following up this either. He's not saying, well, I'll see you in 3 months, which is not the best thing to do, but he's not doing that. Just saying, we'll keep an eye on it, which is not adequate. He's leaving up to the patient to determine when he keeps an eye on it. And you don't leave that up to the patient. Now, we're still on to Dr. A. It's now at 6 months. Then I had pills. And Dr. X gives him his pills and the blood tests. And he mentions a PSA, but he's fixed nothing. What has he done? He's persisting in all the breaches. Simple as that. We're now at 12 months. But Dr. A comes back for his repeat of his statin. He doesn't even think, of course. He hasn't been told because he hasn't been informed. He's unable to make a decision himself. He's unable to say, Mr. X is unable to say, words to the effect. Dr. A told me he was worried. Sometimes this can mean prostate cancer. You know what? I'm going to do something about this, even if he's not worried about it. I want to see a urologist, or I'm going to come back earlier. He's taken away Mr. X's agency. He's taken away the capacity of Mr. X to make a reasonable decision about his own healthcare based upon information he should reasonably know. And that's an important consequence of failure to inform. So he comes back. He looks over the blood test results. The PSA is now 9.2. I mean, it's looking pretty obvious. Nobody's asking anyone here to show, to say, well, gee, I think that, this is an exercise in what one should do about PSAs. This is an exercise in how one should manage patients as a general practitioner on fundamental principles. So he hasn't looked and compared. Well, I'm so sorry. This is now Dr. B. Dr. B. Dr. A has left, as I said, Dr. A has left the surgery, as happens in these multi-practice surgeries quite often. And now Dr. B is looking at it, and Dr. B is supposed to check the previous notes before he sees Dr. A coming in. Now there, and he's supposed to see, or she, whichever Dr. B is, that whether there's any unfinished business. Well, clearly there is unfinished business. And Dr. B doesn't know there's unfinished business because hasn't compared the results of 6 and 12 months ago, hasn't looked at the urine test, fails to follow up, breach, fails to inform Mr. X properly of the results of the 9.2 PSA and its possible implications, fails to inform. Where's the history? Hey, PSA 9.2, I see that you had urinary tract symptoms before. What's going on? What's happening with that? Doesn't take your history. About time the poor guy had an examination. Fails to perform a proper examination. And this is why Dr. B will be a defendant. And not only does Dr. B not interpret the PSA 9.2 as being one that should be viewed with great suspicion. I'm not saying it means that the guy necessarily got malignancy, but I'll tell you what, it's a pretty scary number. But without doubt, the pathologist would have had a comment. I haven't reproduced a comment here, and maybe I should have. But the pathologist nearly always have a comment about a result like that. He doesn't investigate, as did Dr. A. He fails to refer summarily as an alternative. He doesn't. Dr. B does not think, well, what's a reasonable differential diagnosis? It could be prostatitis. Yeah, it might be a really big prostate, but I tell you what, probability of being malignant is quite high. Well, I've got 3 so far. So doesn't formulate a reasonable differential diagnosis and has caused delay in diagnosis. Now, what happens here is that Dr. B is responsible for causing delay of diagnosis calculated from this date. It's a different date to Dr. A. Dr. B gets to own his or her delay in diagnosis. Excuse me, I'm just going to have a bit of tea. Let us proceed. Now, it's been 18 months. Mr. X, who doesn't know any better, has not been told about, well, this could mean he can't make any informed decisions about his own health care. Just being told you're getting older. Comes to see Dr. B. Dr. B's a she. She's on maternity leave. So he sees Dr. C, a locum. Hello, Mr. X, how can I help you, says Dr. C. And as far as Mr. X is concerned, just came for his pills. That's his agenda. Now, there is the matter of patient's agenda. I'll come on to that actually as I go through the points. I'll just come back, I'll do that in order. So Dr. C, quite rightly, goes past Mr. X's agenda, which is his pills. I'll also check your blood pressure. This is opportunistic healthcare. One of the jobs of general practitioner. And the scenario that we see here, by the way, as are all the scenarios very commonly seen, all the stuff that we have here is not out of the box. It's very common. So, what's the consequence of there being a locum? Well, he might be, or she, a fresh set of bright and wakeful eyes, or he could be just seeing himself as a fill-in. In this case, I can tell you now, it's the latter. And it would appear, leaving out the blood pressure, which was, a wonderful initiative, and it was a bit elevated, that Dr. C is taking these instructions regarding the purpose of consultation and management from the patient. It's the patient who's deciding what this consultation is about, as it has been so far. But the fact that Dr. C, by the way, checked his blood pressure does not mitigate his breaches, because it's not material. It might show that he's slightly better than he otherwise could have been, but it's not going to help him here. It's not material. Now, Dr. C might say, well, look, I'm not Mr. X's usual general practitioner. I'm just here filling in. And he came for his pills. I was a really good boy. I took his blood pressure as well. What more do you want from me? Well, the concept of usual general practitioner, which I often see in defense, is fallacious. The role of a general practitioner can't be defined by the patient. The patient can't say, you are my general practitioner, therefore I'm just asking you to do this. This is not a shop. He's not buying a pint of milk. The person who determines whether he sells a pint of milk, gives him some bread and some peanut butter, is the guy behind the counter. That's the role of the doctor. This is not a shop. So the role of general practitioner can't be defined by the patient, because the patient doesn't know enough. That's why they're seeing the doctor. But it must be defined by the medical practitioner. Compared with the only other person in the room, which is the patient, he's the one best qualified to understand what's in the best interest of the patient. And he's the only one who's responsible for the outcomes of the management. Yes, there is, patient contribution and the like, but basically it's not the patient who gets sued. It's the doctor, and therefore the doctor is a person to recognize what should be on the agenda. Now, that doesn't take away agency from the patient, but it's saying, well, I don't want you to do that. But the discussion must happen. Because, readers, this does not take away agency from the patient, because management can be undertaken only with informed consent. So in this particular situation, if Dr. C were to say, oh, you've come for your pills, by the way, I'll check your blood pressure and I'll weigh you. And let's just see what your last cholesterol was like. I'm not interested in that, doctor. I understand, but I think we should look. Can we do it later? I'll put it on the list. Okay. I'm not happy about your prostate test. And if the patient were to say, I definitely don't want to know about that, then the doctor explains why you should know about it and the consequences of not knowing about it. There might be an argument that he does not need to address it because he has addressed it and he's been forbidden to do so. That's not the case here whatsoever, and it's very unlikely to be the case anyway. No rational patient. So, Dr. C has been led by Mr. X's agenda, and all of his breaches are the same as those of the previous doctors. And by the way, the lane diagnosis, I haven't mentioned it there, that gets pasted on Dr. C's notes as well, dated from the consultation number for 18 months. Shall we move on? As you can see, the case itself is very straightforward, but the breaches themselves are, we're looking at the breaches that arise from what happens, and more importantly, what does not happen in these consultations. So there's a phone call. I often see that in the notes. A message is sent to Dr. C. Mr. X says he needs a form for his usual blood test. Well, it's going to come back. Dr. C has now left. What C has? It's the locum. Dr. B has returned from maternity leave and writes out the form, passes the form on to the receptionist, who gives the forms to Mr. X, and he has a test done the following day's consultation. You'd think this was innocuous, but it's not. Let's go through what should happen. What might have happened. I'll make this up, but it's not unreasonable. Is that Mr. X goes to receptionist, was asked to get some blood tests done. The reception says, I'll just ask Dr. B. She's back on maternity leave, had a lovely baby boy. Dr. B says, yes, I know what he needs, quickly writes the form, passes it back out again, gets on with whatever she was doing. Yes. She didn't check the file. She went, she thinks she should have. Well, she should have checked the file, or she should have remembered, which she didn't, of course, and she didn't click to the previous PSAs. And the thing that should have happened here is that Dr. B should have said, oh, look at those PSAs. Well, and told the receptionist, make sure he makes an appointment to see me. Can I get to see him this week, next week at the latest? She hasn't ensured that he's going to return. You say, well, of course he'll return because, well, I see I've got a spelling mistake, by the way, in exceeding. I'm sure he'll return. After all, he wants his blood test done. That doesn't count. You've got to make sure that he does. It is important. You can't leave it to the patient. The patient's not running this particular show. Or at least he can't run it without being properly informed. And if he was properly informed, he wouldn't even be turning up for the test. He'd be seeing the doctor. So, if he's rational and reasonable. So, there was a failure to follow up, another breach from something that looks quite innocuous, but it wasn't. 25 months. So he's had his blood test done. Took a month for him to do it. Well, he's in no hurry after all. He has things to do. He has a life to live. What's the rush? Nobody told him there was a problem. So he returns for a repeat prescription of statin, and the result of his blood tests, he's quite happy. Gets seen by Dr. D because Dr. B's on the surgery on Wednesdays. She's got a family. Fair enough. But Dr. D is a fresh pair of eyes, and he looks at the clinical records. This is novel in the surgery, isn't it? And the cumulative blood tests. And he notes the serial serum PSA measurements and the previously elevated blood pressure. And look to check to see, well, what else has been done here? What are the referral letters? And he finds none. But he does have the latest PSA. 116. I think I've got anagrams, believe I mucked up the units. I do apologize. I'm sure we'll overlook that and I'll fix it next time. 6.5, 9.2, 116. Dr. A knows exactly how this consultation is going to go. He's done his home precaution. Dr. A, hello, Mr. X, come and take a seat. He's going to need one. How can I help you today? Dr. A knows. I've come for my pills. It's his agenda. Of course. There are some other things I would like to go over with you. Dr. A. Actually, that should be Dr. D. I've got a typo in there. Please forgive me. We're on to Dr. D. I went over this many times to try to get rid of the typos. And always something there. This is Dr. D. For A, read D. Of course. But there are some other things I'd like to go over with you. And Mr. X's comment is quite poignant. It's surprise. Huh? Like, what's going on? So, what happens is that inevitably, and it's inevitable, someone could be the same, another general practitioner, specialist, or the patient notices that there is a problem. Sooner or later, these chickens are going to come home to roost. One way or the other, they're going to come home to roost. And unsurprisingly, it's met with surprise. Doesn't know what's coming yet, but it's a surprise. And he asks questions. And what follows the questions? Anger follows the questions. The breach of duty of care is the fuel for the fire, and anger lights the flame. And that's where I usually get a letter of instruction. So, Dr. D continues. Let's just see how the consultation looks now. So, he says, how's the waterworks? Not too bad, but doctor, I didn't come about that. I'm interested in my cholesterol and blood tests, blood pressure. Mr. X is, no, let's not talk about what it was. I'm here just for my cholesterol, my blood pressure. I'm trying to set the agenda. Dr. D, yes, I know, I've continued with the same typo. He doesn't allow himself to be taken off course. I think we need to be, and I'll explain why in a moment. So tell me how the water works. So what happens? Dr. D does take a proper, focused, detailed history, relevant to the urogenital tract. He does perform a proper clinical examination. I mean, it could be quite limited. There's not too much you need to do. He does ask to do a rectal exam, but Mr. X declines. Okay, all right, he's allowed to decline. We don't have to worry. He'll get his rectal exam from someone else. Dr. D explains to Mr. X the likely significance of the elevated PSA, but carefully qualifies it by telling Mr. X, in language that Mr. X would understand, that nothing is really known without a tissue diagnosis. He explains what that means, and that further tests, because it's important not to use jargon. Very often people use jargon. A tissue diagnosis is jargon. You and I know what that means, but you know what? When we were in high school, before we went to med school, we didn't. And it tells him what's likely to be necessary, and he'll refer him urgently to a specialist urologist. And then he goes back and checks that Mr. X actually understands what is being told. Dr. D does some groundwork. It'll save Mr. X a second visit to the urologist usually, because he does all the blood tests. You might have some other tests that you might like to think he should have done, but let's assume these are all the blood tests. These are the tests that a general practitioner would do. And he knows he's going to need some simple imaging of the renal tract. There's no way he's not. So he orders the ultrasound. Might as well get that out of the way. He does not leave the appointment making to Mr. X. He rings. He arranges the appointment. He might actually speak to Dr. X, to the urologist, and he may well to get him in early. He writes a comprehensive referral letter, not, dear urologist, here's Mr. X, please do the needful. Scribbled on a piece of prescription paper. No. He hands it to Mr. X. That's what I always used to do. You can see what's in it. And he makes a note. You might say you don't want to do that. It's a matter of choice, but I always did. And these days you send it directly to the urologist as well. And he makes a note to contact Mr. X a few days later to see that he actually has seen the urologist. And he records all of this straight during or straight after the consultation, so that he has an adequately detailed, contemporaneous clinical record. That's the best defense that anybody can have. So what has Dr. D done? Let's have a look. He set the agenda. Very important. He set the agenda. He did not allow the patient to set the agenda. He took a proper history. He performed a proper physical examination. He answered Mr. X's questions. I didn't mention it, but he answers his questions. Now, this is important. He informs Mr. X of what Mr. X needs to know and what he believes Mr. X would want to know if he knew to ask. Goes back to Rogers versus Whittaker, the ophthalmologist and the patient who was a pain. I'll leave you to check that later if you're not familiar with it. All the lawyers here will be familiar with it. Many of the doctors would be. But not only do you need to tell the patient what you believe the patient should know, but what you think the patient would want to know if the patient knew to ask. I know it's a big ask, but you're supposed to do that. He refers Mr. X to an appropriate specialist in a timely manner, not just gives him a referral or make an appointment. It's got to be done now. Will it make a difference clinically? Well, I understand. He's got a PSA of 116. I do get all that. But it does need to be done urgently. If it was your PSA, you'd want it done now. He investigates him properly. Doesn't have to, but he did, which is very good. He keeps a proper clinical record and he follows up. All those things were done. So the wash up. Mr. X sees the urologist within 2 weeks. Following further investigations and the dreaded rectal exam, He's informed that he has prostatic cancer, palpable rectally, could have been felt, with involvement of the seminal vesicles. That's not good. On imaging will show the left ureter, further investigations will show, obviously not on physical examination, these bits, but the left ureter and the adjacent pelvic nodes are involved. He has his biopsy, it's a 4+4, and he's got hot spots in his bones. Well, he can't be cured. He's offered non-curative treatment for his prostate cancer. And Mr. X calls his lawyer. So, the breaches, what are the breaches here? The breaches attributed to general practitioners, not Dr. D though, at the Maccabi Medical Center and Skin Cancer Clinic include. The reason I say include is you might think of some more. Failure to inform, that would have made a difference. Failure to follow up, that would have made a difference. Failure to take a proper focus history, might have made a difference, but it should be done. Without that, you can't do the diagnostic process. Failure to perform a proper focused physical examination, it should be done. A rectal exam might have felt a lump. Could have even felt it involving the seminal vesicles, by which stage things are pretty well advanced anyway. I understand that. Didn't formulate a proper differential diagnosis, which included cancer. Didn't investigate. Didn't refer in a timely matter. But all of that can be forgotten if any of those doctors referred straight, immediately, urgently to urologist. Yeah, lousy standard healthcare, but no material damage, and that's the issue here. Consequently, there's been a delay in the diagnosis of prostate cancer with the obvious consequences. The causation of which is not determined by the general practitioner, you should stay out of it, but by either the urologist or the oncologist or both. And the breaches of duty of care of the fundamental proper process of consultation, not looking, not knowing and not asking, same goes in there, not knowing what one doesn't know. You know, if the general practitioner said, look, I don't understand PSAs. I have no idea what's going on here. I'm no good at this. That's okay. And they recognize that they don't know that, that's fine. When they're safe, they will refer. And at no time did they act in the best interests of the patient. And that is the bottom line. And that's the end of that. So, is there anything you'd like to ask? There may not be, in which case that's fine. And we can all have an early mark. But if you have.
Yep, so if anyone has any questions, just unmute yourself and just come forward, please. Thank you.
Don't knock me over. I've either done a great job and answered all your questions, or you're all asleep, or just very shy.
Doctor, I just was thinking about what you said about the contemporaneous records are the best defence. Of course, we know that in legal practice too. On occasion, we have suspicions when we're looking at records that they've been altered much later, or whatever. Is there? Do you see any way to one, I guess, prove that, or what should you look for there? I suppose if you think there's something not quite right.
Just be half a second. I'm just going to, because now you're speaking, I'm just going to get my hardware to work properly. 1 second.
Oh, great. You can still hear me, can't you?
Yep.
Oh, great. I can hear you better. Sorry about that, Annie. So what you were asking was what's happening. The sound was coming out over my computer rather than my headphones. What you're asking is what should you look at in the records to know whether or not they've been properly kept?
Yes, and sometimes we get a suspicion, I guess, that they've the records may have been written much after the event.
Yes.
Might have been notified of an adverse outcome and so on. Yeah.
Well, actually, on the last one, I've seen that too, and when they're written afterwards, what you will tend to find, the software is written so that it's virtually impossible to do that. Because when the notes are printed out, they should follow each other on the same page and then roll off onto the next page. And they're obviously serial, a little bit like blockchain, actually, same principle, that, you know, one follows the other with a date and a time. You will notice that, and software will tend to vary. Not all software will do it. But one of them will be that many software will say consultation on, recorded on, and they're two different things. So the consultation on and recorded on should be at the same time. It's not uncommon for general practitioners to write up the notes once the patient's left the room, and that's okay.
Yes.
And sometimes at the end of the day, it happens. You're very busy, and that can happen as well. I mean, we're not perfect. We do our best, and that can happen. And you know, one wouldn't think poorly about that. But what usually raises my suspicions about non-contemporaneous notes are two things. One is when each record is on a separate page.
Okay. Yeah.
I don't like that. That is so easily fudged. All you got to do is just print separate pages on Word. The other one, and I understand this is happening a bit more frequently now. I've had two cases like this, and one just only in the past few days, is where the defendant does not provide the contemporaneous notes, but provides a dump of raw computer records in tabular form, which can be impossible to interpret. And that will always make me wonder why they did that. That brings us then around to your question about, well, how do you know if the notes are good? I'll be perfectly honest with you, that's much more difficult.
Yes.
That is really where you need the eye of a peer.
Yeah.
Because a peer will know what is meant to be there, what sometimes is implied. Sometimes there's an implication of what's there, and we understand what the doctor's thinking because of the way they wrote it.
Yeah.
Even though it's not spelled out. Often actually with with very good doctors, you'll see that. You can see how their mind's working. And you can tell the difference between that and just sloppy record keeping, or where the mind is not working at all. My guess is that there may be ways of determining that later, which are going to be more done through a clever machine, but we're a long way away from that. So I don't have an answer for you on that one. I can tell. You might be able to, and you will I'm sure you have with experience, and in the same way as you can recognize good and bad practice in your colleagues. And you know, many of these things, you just see it and you know. Have I answered that question?
Yeah, thank you. It's a lot of it is that software trick stuff that you can see done, used properly or not, and as you said in the word version, one day each page. Yeah.
Well, I'll give you actually a colourful one. We all love our anecdotes. We all think they're wonderful and exciting. Other people may not. There was a case with a doctor from the was obviously not born in Australia, had a poor command of the English language, which was obvious from some of the records that were provided, which were minimal, and frankly, there were some other clues there as well. I won't be too pointed. These days, one has to be careful not to be, but you could tell. And he provided the notes on a separate page. Now, I tell you what, I've had a really good education in English. I'm the old school. I can parse a sentence. I did Latin for 4 years. I know my indicatives and subjunctives. And his English was fantastic. Like it was Charles Dickens. And everything that had to be done was done to the letter. And do you think I believed that? What happened in the end was that his computer hardware was subpoenaed.
Yep.
And at the last minute, when he was faced with, I'm not a lawyer, but I guess there's something, I think it would be something like false declarations and perverting the course of justice. That probably comes into it. You know that better than me, but it would have been a prison sentence.
Okay.
He caved
Mm.
just before. So that was a case which I thought that was interesting.
Yes, that is. So had that person run everything through Google Translate or something to
No, he got a mate. He got a
Oh,
mate.
right.
I'm sure it got a mate. Even Google Translate will make certain errors.
Yes.
And Google Translate will not write medically amazing notes where every part of the history and every part of the examination was expertly done. Like, you say, wow, he's more anal than me, and that's going a long way.
Right. I guess that that chat GBT AI stuff is the next area.
That will be the next, yes. And we do have to keep an eye open for that, yes. But you're still going to have the matter of being able to reproduce the notes serially, and don't worry, and then don't forget, you can always grab the hard drive.
Yes, good. Thank you.
It's a pleasure, Amy. Anything else? No, nobody's jumping out at me. I must have done something wrong.
Thank you, Amy, for the question. So if nobody else has any questions, I guess we'll wrap up the seminar here. Does anyone else have any other question? Last chance.
Just to say thank you.
It's a pleasure. It's a
Thank
pleasure.
you.
And thank you to everybody else as well. Thank you, Amy. Thank you, Michelle. Thanks for everyone.